So without further ado, it's really my pleasure to introduce Dr. Nahar to give an introduction to the book. Thank you.
Thank you, Dr. Chi Ijiofil, for your kind introduction. Thank you to everyone for coming today. I'd especially like to thank Brighton and Sussex Medical School and CORTH of Sussex University for organizing this event and giving me this opportunity to discuss my book. It's a great honor to have Professor Maya Unnithan and Professor Trudie Gerrits as panelists in this event. I'm particularly delighted to have Professor Trudie as a discussant, who was my teacher at the University of Amsterdam and one of the pioneers of infertility social science research, and Prof. Maya, whom I share similar academic interest with. In what follows, I will briefly highlight some of the issues of themes of my book, Childlessness in Bangladesh, Intersectionality, Suffering, and Resilience. I'm happy to take questions, and please feel free to ask questions after my presentation. I think I need to share my screen now for the presentation. Experts in the Western world refer to the inability to bear children by various terms, including infertility, childlessness, and sterility. WHO stated infertility as a disease of male or female reproductive system defined by the failure to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. There are two types of infertility. Primary infertility refers to the couples who have never been pregnant. Secondary infertility refers to who have been able to get pregnant at least once, but now are unable to get pregnant. Estimates suggest that 48 million couples and 186 million individuals live with infertility globally. 1 in 4 couples in low-income countries have been found to be affected by infertility. I use the term childlessness as all my study participants were not necessarily biologically diagnosed as infertile. I'll talk about this a little later. Childlessness can be voluntary or involuntary. My book is about involuntary childlessness, but in this presentation, I'll be using both the terms interchangeably, childlessness and infertility. Now I'm going to talk about the route through which infertility became a scholarly topic. Infertility was neglected globally in general and in non-Western setting in particular. The various reasons that are identified for infertility being neglected topic are: historically, involuntary childlessness or infertility was often classified as a medical problem rather than a social problem, deserving social analysis. Infertility has been a taboo subject for a long time, which is not easily discussed with others, not even in neutral research settings. For the non-West, common excuse are overpopulation and limited resources. Infertile subpopulation in high fertility non-Western setting have never been treated as a high priority in international population discourse and may even be viewed as contrary to Western interest in global population control ideology. On the other hand, as a result of feminist revolution in 1960s, at least in the West, childlessness can be chosen as a lifestyle option and for some as a feminist statement. Consequently, childlessness has been placed in the ambiguous position for them. When feminist writing addressed infertility, they focused mainly on new reproductive technologies and have focused almost entirely on the Western settings for a logical reason. Marcia Inhorn was one of the exceptions who started studying infertility issue in the non-Western context from anthropological perspective. In early 1980s, certain public health practitioners began to plea for a wider definition of reproductive health and family planning that would include issues such as infertility. The international women's health movement and other women activists in 1970s, 80s, and 90s also raised the voice against the narrow focus of health and family planning programs. Finally, since 1994, during the ICPD Cairo conference, infertility has been accepted as a basic component of reproductive health care. This resulted in a greater focus on the issue within academia as well. Gradually, literature on infertility in the public health, anthropology, sociology, and some psychological studies started emerging. It has been well documented that infertility carries a social construction based on complex set of beliefs and values that in turn shapes the meaning of infertility within a society. Anthropologists have documented the ways in which society regulates the politics of reproduction and deal with the issue of reproductive impairment, as well as differences in reproductive motivations in different societies. Infertility is therefore a complex interaction between not only biological and cultural, but also structural factors, and can be a source of social, psychological, and economic consequences. With this background, in this book, I have presented the lived experience of childless women in Bangladesh, recognizing that women in Bangladesh are a heterogeneous group. I highlight the roles gender structural forces and intersectionality play in the experience of these women, as well as their strategies of resistance against social vulnerability. These are the three concepts that I have used to interpret my data. These concepts are intersectionality, suffering, and resilience. I have taken an ethnographic approach to conduct this research, and I have conducted life history method with 20 rural, poor, unlettered, involuntary, childless women and 11 urban educated middle class infertile women. I have also conducted participant observation and participant rapid appraisal, including body mapping, pulse sorting, severity ranking, and free listing. I have also done key informant interviews with the government, NGO, and UN organization representative, including private sector, private healthcare providers. Bangladesh is the 8th most populous country in the world, with a population exceeding 163 million people. It is one of the most densely populated countries. It's a predominantly Muslim South Asian country. Although feminization of employment has taken a place in Bangladesh with increased involvement of women in various industries such as garments, this has not significantly altered the subordinate gendered position assigned to women. However, women in Bangladesh are not a homogeneous group, rather come from diverse socioeconomic and cultural background, ranging from highly educated, affluent to unlettered poor women. No national study has been conducted to determine the epidemiological facts surrounding infertility yet. However, Bangladesh has a high prevalence of risk factors, infertility, including STD, reproductive tract infection, and so on. Social reaction to infertility are directly related to the value of fertility, in other words, to value of motherhood. Historically, motherhood is seen as a glorified position for women in both Western and non-Western cultures, regardless of whether a mother's life is as glorified in reality. In Bangladesh, however, the dominant state ideology is to control fertility. Consequently, the family planning program is a success story of the country. The total fertility rate was above 7 in the early 70s, but it is now merely 2.2. That's a sharp decline for any context. Although it is an antinatalist state, as a society, Bangladesh is a pronatalist society. All dominant religions of the country, Hinduism, Islam, and Buddhism, pay high tribute to motherhood. Due to the absence of a welfare system, children are necessary to secure parents' survival, and they serve as a valuable power source, not only for through economy, but also for other religious and cultural reasons. In societies where motherhood is highly valued, childlessness destroys the identity of womanhood. In this context, I have conducted my research on childlessness to know how it is like to be a woman without having a child. While I explore the cultural construction of infertility in the rural Bangladesh, I found how the community diagnosed infertility through social scrutiny. For example, when a married woman does not conceive within 1 or 2 years of her marriage, she is considered infertile. To indicate a man as infertile, however, the community wait either until his old age or to see outcome of many subsequent marriages. By the way, this is true. This is data from the rural community. While exploring the local vocabularies of infertility, the study revealed 18 terms for childlessness, most of which are used for women and have got negative connotation attached with, and only a few terms for male, which are usually neutral. Here are some examples on the screen. This is a rural proverb which demonstrates the strong source of stigma for infertility, as you can see on the left side of the screen. Through the pulse sorting exercise, it has been revealed the community considers infertility more as a social problem rather than a health problem. Severity rating exercise revealed childlessness is one of the top 3 everyday life problems for the sufferer. The exploration of cultural construction of infertility confirms that infertility provides social identity to the sufferer, commonly a woman. 4 naturalistic and personalistic categories of perceived causes are found for infertility in this rural community. And an ethnophysiological creature called juha-juhi was found to be the main perceived cause for infertility. The experiences of rural and urban childless women in Bangladesh vary due to their different lifestyle and identities. In comparison to urban childless women, their rural counterparts face more pronounced societal pressure of blame and accusation. Rural women face divorce, violence, remarriage by husband, and abandonment as consequences of their childlessness. The well-being of urban childless women is affected in a different form. They suffer a loss of privacy, social isolation, and low self-esteem. Although both urban and rural childless women face blame for their inability to bear a child, the accusations are different for these 2 different groups. For rural women, the stigma is much more open, whereas urban childless women experience a more subtle form of stigmatization. The meaning and value of a child differ between urban and rural society. However, the sanctity of motherhood is the same in both groups. Both feel that they run against the social norm and that their childlessness results in social deviance. An urban infertile woman who was a PhD student at that time expressed the way she feels as an incomplete woman. This is a quotation from a rural involuntary childless woman who described her lonely abandonment and isolated life here. Treatment cost for assisted reproductive technologies is the main economic concern for urban middle-class childless women, whereas for rural poor, there are at least 6 concerns. I'm not going to go into detail, but particularly because of the husbands, because husband became demoralized and so earn less, where there is no child at home. Medical pluralism is common in Bangladesh healthcare system. Women usually are the main focus for fertility treatment. Rural women depend almost exclusively on the traditional healing system in absence of availability of infertility treatment in the formal sector. They constantly keep trying within the traditional domain, resulting in a never-ending and lonely journey to the goal of motherhood. As a result of medical pluralism, on the other hand, urban childless women who predominantly depend on biomedical system also seek treatment solution at certain point in their treatment pathways for varieties of pragmatic and spiritual reasons. My study revealed how urban middle-class women in Bangladesh embarking on IVF journey must navigate complex and uncertain terrain. It is apparent that the health-seeking journey of Bangladeshi childless women is stratified. The intersectional position of a childless woman determines the nature of her health-seeking pathways. However, commonalities were also observed in which both rural and urban childless women typically initiate their own treatment and both face intense experience along their respective treatment-seeking journey. And ultimately, both of them continue their treatment-seeking journey lonely. Interviews with the stakeholders reveal that infertility in Bangladesh is not a priority on anyone's agenda. The lack of infertility service in the public health sector indicates a failure to ensure health equity in the system. Infertile women who are considered undesirable and unaccepted by their society also undergo a process of exclusion by the state. It shows how infertile women lives have not been seen, known, and identified in the macro level conceptualization of women's health. It confirms the ongoing invisibility of infertile women's life at both micro and macro levels. Even though the childless women in Bangladesh suffer profoundly from various forms of ostracism, they do not allow themselves to be defeated. Rather, they find ways to succeed in carry on with their lives. They demonstrate resilience, building on their inner strength and social inventiveness, utilize various everyday forms of resistance proposed by James Scott. The urban women's greatest advantage over rural women is that they have far more alternatives in life to help them escape from the ideal and stereotype mother, quote unquote, role. Through an ethnographic exploration of embodied experience of childless women in Bangladesh, I demonstrated how suffering due to childlessness among Bangladesh women is shaped by the local moral world. Furthermore, I demonstrate that this suffering is plural. The study also demonstrated the intersectionality of childlessness in which rural and urban Bangladesh childless women experience the consequences of childlessness differently due to their different socio-cultural positionality. This is because the power of the society intersects differently with them. Finally, I argue that women who are marginalized are not empty vessels, but rather they play against power through everyday form of resistance using their social and symbolic capital. I will conclude my presentation with the concept with which I had started writing my book, the concept of negative knowing. It refers to the paradox of noticing things and people more in their absence than in their presence. This epistemological path, along with its obstacles, brings us closer to understand the meaning of both pregnancy and the birth of children. Since the absence of children allows one to realize the significance of their presence, this raises the question, what are the lived experience of this negative knowing among the childless? The book shows the experience of childlessness, particularly for women, can be much more severe than what is defined as infertility in the biomedical context. While high-income countries have already progressed towards debate and discussion around the advanced developments such as egg freezing, through this book, I argue, however, that progression in infertility research constitutes much more than simply the advancement and adoption of reproductive technologies. The quality of life of infertile women still remain an under-addressed issue because the problem of women's health is merely measured by the epidemiological extent of the problem the intensity of the problem is not included. Through an anthropological study, I have tried to address this issue. As Veena Das suggested, quote unquote, anthropological text may serve as a body of writing which lets the pain of the others happen to it. Thank you. I'll stop sharing my screen now.
Papreen, thank you so much. You certainly appealed to all of our curiosity to learn more of the themes that you've elaborated on in your book, and it's really great to hear from you, to hear your presentation of the work. And I'd really like to welcome Professor Trudie Gerrits to give your reflections, Trudie, on reading Papreen's material, reading the book, and curious to hear your reflections.
Thank you, Xi. And also Papreen and the organizers of this book launch, I really want to thank you for the invitation to say a few words about your book, which is titled Childlessness in Bangladesh. First of all, Papreen, I really want to congratulate you with this great achievement, which shows your perseverance and dedication to the topic of this book. So I know you started early in the 90s doing a small study on STDs and HIV/AIDS, and then you stumbled on the issue of infertility, and that already struck your attention. And then you realized this is not only a biomedical problem, but it is much more than that in the Bangladesh context. So when you had the opportunity to do your PhD, you happily continued on this topic. So, and then I remember very well that you defended your thesis in 2007 at the University of Amsterdam. Well done. And after that, you have published a great number of articles, and you have given lots of presentations and tried to also to influence policymakers with your findings and with the results of your study. So I think this is really fantastic. But at the same time, also your study findings, they underline the importance of paying attention to this theme of infertility on International Women's Day, as your study really points to so many aspects where the lives and the rights of women can and should be improved. So thank you for organizing this event on this particular day, I would say. For me, the great strength of your book, Papreen, is the richness and depth of the ethnographic material you are presenting. While I personally know the anthropological literature on infertility quite well, I've rarely read such impressive, convincing, and often heartbreaking stories about the suffering, consequences, and stigmatization of infertility in your country. In my comments and questions, however, I'm not going to focus on the stories of suffering and stigmatization, but rather I will focus on the chapters where you analyze how infertile women themselves react to that suffering, and also the chapter where you show how the Bangladesh government and civil society completely neglect it. For me, these chapters were the most innovative and original ones and give ample food for thought. So again, thank you. Free. Let me start with chapter 7, where you list a whole series of reaction and actions from the side of the infertile women that you, in your analysis, you interpreted these actions as agency, resilience, and/or resistance. And these actions include, for example, rural women trying to earn their money to be able to cover the expenses for their treatments, as nobody else supports them in covering these expenses. And women are also, what you're saying, attempting to prolong their fertility-seeking treatment process as much as possible, both with traditional healers and in the biomedical field, from the idea, or at least the hope, that their husbands will not abandon them as long as they are actively trying to resolve the infertility problem. Women and men, not men, are also tolerating all forms of abuse to avoid being abandoned, you're writing. And for the same reason, they also behave as very good citizens at community level, all as sort of efforts to not be abandoned. In addition, you say for the urban class women, you describe how some of them are able to find new positive identities through having a rewarding professional career or finding fulfillment in other societal respected tasks as taking care of children. After having read the previous chapters where you depicted the intense suffering and the severe marital, social, economic, and other consequences of infertility, it was in a way a relief to read that at least part of the women you spoke with found a way to live and cope with it. Still, and here comes my question, I find it a bit difficult to consider these acts as conscious acts of change, as you describe them. I would rather be inclined to see these actions as a sort of desperate attempts to live with a dreadful situation, rather than acts of change. By putting it like this, aren't you also, as some social scientists have been accused of, a sort of interpreting what you are seeing to avoid depicting your study participants as passive victims only? I would like, if time allows, to hear your reaction on that later on. Further, and this is also related to the issue of resistance and agency, you are explicitly mentioning that women are resisting individually, not in a collective or coordinated way at all. And this remark made me think of an article that I, together with some colleagues, recently submitted about ways to fight against infertility stigmatization in low and middle income countries. In this article, we make an inventory of interventions that intend to mitigate infertility stigmatization. And in that article, we are starting from the idea that this should not be left to individual actions of the people facing fertility problems themselves, but that this can or should be supported by systematic interventions and activities initiated by, for example, peer support groups or patient groups, activists, NGOs, the public health sector, and so on. And in that inventory that we made, we found in different country contexts, individuals and organizations are making use of all sorts of media, both the traditional and the new media, like the internet and social media, to spread information about infertility, for example, that also men can be blamed for that, to speak against stigmatizing stereotypes, and to support and empower people facing fertility problems instead of blaming them for it. So, and in some places, we also came across the coming out of celebrities and first ladies who drew attention to the topic of infertility, aiming also to decrease the stigma attached to it. In some countries, we also found patient organizations lobby with policymakers to provide better infertility care. And so my questions to you, Papreen, are, would you think that in Bangladesh, with a country with an abundance of NGOs and activism in the field of SRHR, would there be any space for development of this sort of interventions? Are you aware of this sort of activism in this field in your country? And what do you think can be done to activate people to undertake this sort of action in this field? So I'm saying here also, it's not only about medical intervention. So people always think like, oh, these things are expensive. If you want to tackle infertility, you have to think of AFTs only. But I think there are many other things that can be done for that. And then finally, and that is narrowly related with this issue, the point that you are making in chapter 6, where you say that both the government and civil societies are completely neglecting, denying infertility as an SRHR problem. And worse even, they are pointing to each other, including international donors, to explain this neglect. They say, as long as others don't put it on their agenda as an SRHR issue or priority to be addressed, why would they, donors, NGOs, the state, do it themselves? So You are even referring to this as state violence, next to the violence the women are suffering from at marital, family, and societal level. And here again comes my question. Worldwide, over the last year, I'm observing a bit more attention for infertility, also in low and middle income countries. And I would like to hear from you, Papreen, if time's allowed. Since your study, have any developments taken place in Bangladesh? Have you seen any attempts to put the issue of infertility on agendas? And what, according to you, should happen to get this topic on SRHR agendas in your country? So these are my comments for now, and looking forward to your reaction and the discussion after my presentation. Thank you.
Trudie, thank you. We're really lucky to hear your reflections on this great piece of work by Papreen Nahar, and also the questions that have arisen from your analysis and reading of this work. And I hope we have time to address those questions, and I can see questions amassing in the chat as well. So very exciting to see how our discussions can move forward with it, both within this meeting and perhaps beyond this meeting space. Professor Maya Unnithan, would love to hear your reflections on Papreen's book. I can invite you. I can unmute, I'll help to unmute you if I can. No, I can't, I'm not host.
You can hear me, right?
Yes.
Thank you very much, Chi, and thank you, Papreen, for the opportunity to provide some reflections on your book. Having worked on issues of childbearing and infertility in India since the 1990s, I very much welcome the growth of scholarship in this area. And particularly so because the incidence of childlessness and infertility remains staggeringly obscure in maternal health policies and programs, despite the emphasis in global development on women's empowerment. So there's an ever-pressing need really to understand the complex intersectional factors that underlie this widespread prevalence of high levels of childlessness through precisely the kinds of studies that you are doing, which focus on the micro practices and subjectivities, as well as the institutional cultures of governance that accompany them. So a key aim, I think, of Papreen's book on childlessness and suffering of rural and urban middle-class women in Bangladesh is to highlight the anthropological perspective on infertility. That is, thinking about infertility as a social rather than solely a biological condition. As scholarship on social reproduction and childbearing in India and elsewhere in South Asia, the Middle East, and Sub-Saharan Africa has shown, women are made into persons, that is, they gain societal value and status through childbirth, which then in turn ensures them social and cultural capital and the material resources necessary for well-being. Childbirth ensures that marriages remain secure and a woman's identity, integrity, and belonging as a mother within the social group is assured. So childlessness then, by contrast, disrupts all these securities. It entails a loss of personhood, limited entitlement to material sources, fragile social relationships, and little hope for well-being, both at the time of the discovery of childlessness, but also into the future, because childless women are most likely to be divorced or abandoned. So where women as mothers then become so completely responsible for the social reproduction of the lineage, the family, and the community, childlessness then becomes this condition of great anxiety and moral concern. Because procreation and its failure, when viewed in this light of what has been stated as the mandate of motherhood, gains then a very different and terrifying aspect for women. Papreen documents this in wonderful detail, describing the physical and psychological violence that unfolds, where her women respondents, to quote, can't see a single advantage of not having children. The feelings of blame, guilt, and failure completely devastate women's sense of self, further reinforced by a societal erasure that takes place, wherein they become absent in their very presence. And that is kind of reflected in this notion of negative knowing that Papreen and others talk about. That is, it's a social erasure where other members of the community kind of ignore, avoid, or openly castigate childless women. So the sense of moral failure and social castigation experienced by women, this actually resonates strongly with my own work in Northwest India, where I suggest that in fact, women who bear children are also affected, in that women who have already successfully given birth to a child have a deep anxiety that they will not bear perhaps enough children, that is, children of the right number or of the right sex. And this fact is further borne out by the fact that both childless and women, childbearing women, now a number of these women, they all seek advice and intervention from both healers, indigenous healers, but also biomedical practitioners. And this is the same, I think, across Northwest India and Bangladesh, as Papreen documents. So seeking help from a range of practitioners at the same time also suggests that women are not passive sort of victims, but rather actively engage and seek to mitigate the kind of social, economic, and psychological consequences of their childlessness. In an insightful chapter on resistance, and this is also as Trudie has discussed in her comments, Papreen suggests that there are different kinds of strategies, pragmatic, resilient, confrontational, that are adopted by her respondents. So she analyzes agency in this context as kind of primarily class-based and stemming from the diverse experiences of childlessness between rural and urban childless women, with the former, she argues, feeling a greater collective pressure than the latter, the urban women, who are able to realize their actions because of their greater individual autonomy. The focus on class difference, I find, while it is important in that we see how women may remake alternative identities for themselves in terms of employment, say for the urban women, was, however, one I found at times kind of flattening out the richness of the ethnographic observations in the book. But just, I know time is, we don't have that much time, but finally, I'd just like to come back to the central point about that Papreen makes in the book about infertility as a social and not a health problem, to suggest that perhaps it may be sort of beneficial to link the two in specific kinds of cases, such as in the context of secondary infertility. That is, when a woman can't bear a child after she has had her first child. So because I think secondary infertility is caused, at least in my knowledge, through a high level of reproductive tract infections. And so in that context, early biomedical-based health intervention would likely provide a solution in these cases. And this would then possibly be a small but significant step to redressing the physical and psychological suffering associated with childlessness. So it would be good to hear perhaps from Papreen, if we have time in the discussion, to really think about what your thoughts are on this. And to sort of look more closely at what can be done in the context also of in light of what Trudie's suggestions have been around civil society and collective kind of mobilization. More broadly, I think, and to conclude, I think, as I see that this sort of detailed research by Papreen as described in her book as contributing to critical work in the area of reproductive justice by bringing more public and policy visibility to a pervasive condition of suffering that we find in the context we've worked in. I'm going to stop here, and I'm sorry I don't have enough time to do all the chapters justice. But thanks again for this opportunity, Papreen, and huge congratulations on your book. Thank you.